Recording for this meeting has begun.
And will be available on the ICC's website at www.canceriowa.org. So during today's webinar, we'll be hearing from 3 different presenters. John Peterson is the Community Development Director for the City of Ankeny and a member of the American Planning Association. And his presentation will be titled At the Intersection of Health and Planning. Dr. Lynn Novilla is an associate professor at Brigham Young University in the Department of Health Sciences, and she will be presenting Deconstructing Health in All Policies, Health as a Common Goal. And finally, Denise Attard-Sacco is a public health consultant and health educator in Iowa, and she will address health determinants through health impact assessment and a health lens analysis. So just real quick, I'm going to walk you through some of the webinar features. So the webinar is in listen-only mode, so you'll be able to hear only through your computer speakers. In the bottom right corner of your screen, you'll see a chat box where you can interact with others on the webinar and ask questions to the presenters. Questions will be answered following the presentation. In the upper right corner, you'll see a files pod where you can download the handouts that are mentioned during today's presentation. So to do that, all you need to do is select the file and then click download file, and it will be downloaded directly to your computer. If you have any technical difficulties during the webinar, please let me know using the chat tool, and we will do what we can to resolve your issues. So as we get started, if you would please enter your title and your organization in the chat tool so we can get a feeling of who is joining us today, that would be great. And we will get started with John Peterson's presentation.
Great, thank you, Allie, for that. Just to quickly get started, I am with the City of Ankeny and represent the American Planning Association. We have gotten active in trying to connect planners with health professionals, and that's part of my role with the association. I want to take us back a little in history to when planners the planning profession actually started, and when public health was key to that. Back in the 1800s in Europe, late 1800s, early 1900s in the USA, situations were poor. There was a lot of overcrowding, poor sanitation, disease, poor water quality, air quality. It's interesting to do that research when you go back and look at photographs or drawings of that time. It's typical to see the factories belching smoke and trash and filth on the streets, and tenement housing, and disease was rampant. Disease is typically pictured in those books as skeletons representing cholera or tuberculosis. And because of the density of population, those diseases spread rapidly. A variety of things have changed, but it wasn't until the the 1920s, really, in the USA, that enabling legislation was adopted to allow communities to create zoning standards and planning and enforce those, targeting mainly health and safety of our population, but providing for separation of uses, providing for light and air and access to light and air. And along with that came the technology of water systems and sewer systems that begin to help with a lot of that. Again, those separated uses, many communities still have what's termed as the old Euclidean zoning, which is was intended at the time to separate uses that had adverse impacts on other uses, especially residential. It's time again for public health professionals and planners to come together. There's an impetus now. Chronic disease is reaching epidemic proportions. I'm a poster child for some of that. I'll tell a little story on myself. Several years ago in the doctor's office, he was looking at blood work reports and said, well, I'm going to prescribe this medication to you, or you can go lose 40 pounds. And as we had those conversations, it really became apparent to me that being able to stay physically active and control diet and have healthy diet choices was very important, not only to me, but to a lot of our population. Health professionals, there's a great little parable, public health parable, 3 doctors standing along the river, pulling drowning people out, resuscitating them, bringing them back alive. One doctor turns and starts to walk up the river upstream, and the other 2 doctors say, well, wait, you don't have time. We have all these people we have to save. And the doctor walking upstream said, well, let's go find out who's throwing them in to the river. And that little parable says a lot about where public health is moving. And public health is moving upstream, trying to move away from prevention, although that's still critical, but trying moving away from treatment and trying to move toward prevention. That's where the connection becomes important with planners. About 10 years ago and ongoing now, the American Planning Association created a Planning and Community Health Center, which focuses its efforts on active living, food systems, and health in all planning policies. So our planning organization in the country, our lead planning organization in the country, is really working to connect planners and public health, again, to help solve problems with chronic disease and with making more provision for healthy food choices. I took a little bit of time, and the reference that I used was from the National Association of Local Boards of Health. In Iowa, in 2010, our legislature finally adopted smart planning principles, which give guidelines to cities and regions on elements that should be included in comprehensive plans. It doesn't require comprehensive planning, but it provides for a structure that communities could use to do comprehensive planning. Unfortunately, there's no mention of health in the standard other than that those guidelines will be used to protect health and safety of people. But this document from 2006 really takes the smart planning principles that we all are probably aware of and connects them to health outcomes. You begin to see those things that we do to improve social and cultural capital, decrease depression and isolation. And there's a series of SMART principles that address those things: collaboration, transparency, revitalization, housing, and on through those SMART planning principles. We can see the health outcomes that become apparent and impacted by what we do in those areas of SMART planning. So there is a connection, and more studies are showing the connection between activity and healthy food choices and a person's health. Today, across Iowa, there are a number of projects that are addressing active living. A new project just getting started in the city of Marion that was funded through a grants program through the American Planning Association, grants program called Plan for Health. That active living standard will take complete streets and move beyond that to try and provide some guidelines and guidance to the city of Marion on how to create a more active lifestyle in their community and improve the quality of life and quality of health of their citizens. We hope to spread that statewide with some examples and case reports on that as we go. Trail development promotes active living, also promotes social connections, and that's statewide again, stronger than ever. Communities are beginning to see the benefits of that and creating events around the trails, which are also very positive from a social capital standpoint. Activating spaces, I had a chance to speak at another conference on activating space. There are a lot of public spaces, but how we use them becomes important to create social capital and active living. And so it's important for planners to think about ways that spaces will be used and how to create spaces that can be used for a variety of purposes. Shared space, the joint use of facilities in Ankeny. For instance, the school district opens the gymnasiums in the evenings. The city rec program, rec department runs and provides supervision of those gyms. A number of recreation programs are run through that space, that public space. Really, without regard, it's a community space, not necessarily a school space or a city space. Sidewalk audits, Chris Seeger up at Iowa State, the iWalk program, all across the state. They've done walk audits for communities and recommended either the installation of walkways or improvements to street crossings that will make walking more safe and more available to people who want to live an active life. Walking school buses is the final one on the list, and there's a great resource at the Department of Public Health that's a guide on how to do, step-by-step guide on how to do walking school buses, trying to get children and parents comfortable with actively going to school as opposed to sitting in the car in a drop-off lane waiting to get dropped off for school. So a lot of work on active living. Also a lot of work on healthy food. again, across the state. Jason Grimm over at the Iowa Valley RC&D working on food system planning in the Linn County area generally, where they're trying to connect producers with processing and consumers, including restaurants, to provide healthy foods in restaurants and make it more accessible to the people in the area. Food labeling, ongoing efforts to provide labeling of food. Where did it come from? What are the ingredients? Hy-Vee grocery stores here in Iowa do a great job with a scoring system that helps people make educated choices about the food they're choosing to eat, giving them the opportunity to make healthy choices. Food pantries, we've got another little project that's funded by the Plan for Health program. Heartland Area Community Action Council in Linn County will be preparing guidelines for food pantry directors that will show them how to incorporate healthy foods into their mix, into the food that they're offering to the users of those food pantries. Great project. Again, stay tuned. Those are just getting started. Community gardens. Community gardens are popping up in a lot of places, including churches and schools. We have a great example of a teaching garden that's being developed on the west side of Ankeny by Ray Miller. Ray has got an incredible connection to the science of the ecology of the food, the ecology of the earth, how we can make the earth healthier, make the food healthier, bringing classrooms out to learn where food comes from, working with veterans on how to cook healthier meals, how to cook food from a garden, all those types of things. A very, very great program that Ray's starting on the west side of Ankeny. Farmers market food boxes. This is a idea that I heard as we begin to talk to food pantries. Farmers markets, oftentimes the vendors will have leftover produce at the end of the market. They've asked vendors to donate, to fill boxes that can then be taken to food pantries so that, again, people using food pantries can have some healthy food choices. And finally, just another example, Dallas County Department of Health has been working to get healthy food options in their vending machines at their work sites. Great program to give people the choice to choose a healthy option for food. Why should we connect? There's a variety of reasons. In my world, about 6 years ago, we've been working for a long time in Ankeny to be an active community. I was asked by a friend to join into a group, the Iowans Fit for Life program, and they had a subcommittee that was working on community design, actually writing guidelines and standards for how to do complete streets. An amazing little connection is half the people around the table were public health people. So while we were on parallel paths, public health working to get more active communities, planners working to get more active communities, until that moment I didn't realize the connection between the two. And things have changed quite a bit since then. I've had an opportunity to be involved with the Iowa Community Transformation Advisory Group, with the Iowa Public Health Association, a small group in Des Moines, Healthy People, Healthy Places. That's a collaborative group trying to find ways to educate people on how to live healthier lifestyles. And now our APA Iowa chapter that's doing some work. But planners in their roles, whether they're regional planners, county planners, consultants, or city planners, have connections to people in their communities that make development happen and have the opportunity to influence that development, to think about making it more active, to look at it from a health lens standpoint, bring health professionals in to see what tweaking could be done on projects to provide better access for healthier choices, whether it be active living or healthy food. We're doing the same things. We're just not talking about it all the time.
Okay, wonderful. So I'd just like to mention, if you recognize this building, This is the Iowa State Capitol, and it's located in Grand Avenue in Des Moines, Iowa, which is Iowa's capital city. It was constructed between 1871 and 1886, and it's the only Capitol building in the nation decked with 5 domes. It houses the legislative branch of the Iowa government, which would be the Senate, the House of Representatives, the Office of the Governor, as well as that of the Attorney General, Auditor, Treasurer, and Secretary of State. Having the Iowa State Capitol as the background for my slides in discussing health in all policies is really intentional. Because at the heart of health in all policies is leadership across sectors and at all levels of government. By deconstructing the health in all policies into its basic elements, we hope that this webinar will help meet the knowledge needs of urban planners and provide ideas on how planners can link their efforts with public health for a healthier Iowa. Ali, I'm trying to change my slides. May I get help with that one?
Is that, so if you just press the down arrow.
For some reason, okay, there you go. Can you see that now?
Yes.
Okay. So the intersection between health and urban planning is not only natural but essential. So to determine how we can help strengthen the link between public health and the planning sector in Iowa, we explored how much both sectors actually share a common language in health. So we surveyed the members of the Iowa chapter of the American Planning Association. So when we asked them how familiar they are with the concept of health in all policies, only 5%, or about 6 people out of the 150 that answered this particular question, consider themselves very familiar with the concept of health in all policies. When asked about how familiar they are with the social determinants of health, likewise, only about 15% of the respondents, or about 17 people, consider themselves as being very familiar with it. Allow me to actually go back onto one of these slides, which actually shows you how interested planners are in learning more about the social determinants of health. More than 74% of them actually wanted to learn more. Now, on having a common language for health, we asked development planners in Iowa on how familiar they are with public health terms used in conjunction with health in all policies. Generally, Iowa planners are very familiar with the concepts of at-risk or vulnerable populations, environmental justice, as well as social justice. However, planners are not as acquainted with 5 out of the 8 terms we asked them, such as health disparities and health inequities. As you can see over here, the pie graphs show that we have only about 20% or 17% of the respondents being familiar with health disparities as well as health inequities. And again, a very similar percentage came out for health outcomes and cultural competency. So allow me to define now the following terms: health disparities and health inequities. Health disparities and health inequities are often used interchangeably, and they refer to differences in health. However, not just simple differences in health, but a subset of differences in health that are inequitable, unjust or unacceptable, or avoidable. And these are actually differences in health that are usually found between worse as well as better off people in terms of health. And this could be seen along racial or ethnic lines, gender, as well as also socioeconomic positions. In terms of health outcome is really the effect of the process it has on the people targeted by it based on the World Health Organization definition. The next one is cultural competency. It's the ability to understand and respect values, attitudes, beliefs, and mores that differ across cultures. And then having also the ability to consider and respond appropriately to these differences. So the next few slides will actually feature the various definitions for health in all policies coming from various organizations. The very first one came out in 2012, a guide for state and local governments, which was created by the Public Health Institute, the California Department of Public Health, and the American Public Health Association. And this was based mainly on the experiences of the California Health in All Policies Task Force. So based on their definition, it's a collaborative approach for improving the health of all people by incorporating health considerations into decision-making across sectors and policy areas. In 2013, another definition came out from the Association of State and Territorial Health Officials. It was very similar to the definition provided by the Guide for State and Local Governments from California. The strength of these definitions is that they identify what health in all policy is, the ultimate goal, and how and at which levels it can be achieved. However, the main weaknesses of these definitions is that they do not actually explicitly name accountable actors. A more commonly used definition in the literature of health in all policies actually comes from the 2013 Helsinki Statement, in which it defines health in all policies as an approach to public policies across sectors that systematically takes into account the health implications of decisions, seeks synergies, and avoids harmful health impacts in order to improve population health and health equity. It improves accountability of policymakers for health impacts at all levels of policymaking. It includes an emphasis on the consequences of public policies on health systems, determinants of health and well-being. The main strength of the 2013 Helsinki Statement is that this definition explicitly identifies policymakers as the core, as those who are mainly accountable for being transparent in articulating as well as considering the consequences of public policies. Just last year, NACHO, or the National Association of County and City Health Officials, came up with this particular definition. Although very familiar with the last three that I have just discussed, the main strength of this definition is that it actually defines health in all policies as a change in the systems, not just a collaborative or innovative approach, but how we do things in government, whether it be at the local, state, or federal level. So if we were to combine all of these definitions on health in all policies and have a play on words, it will take us to the very core of health in all policies. That is, health in all policies is equal to all in health policies, having all act together in health with health as a common goal. So what are the what, who, when, where, why, and how of health in all policies? So using the most commonly words in these definitions will give us the basic elements of health in all policies. Who are we targeting mainly? Leaders, policymakers, and in reality, any decision maker whose decision could actually impact population health as well as health equity. What is health in all policy? It's an approach that is really a policy response to inequities in health. Where can we apply health in all policies? Across sectors, at all levels, the whole of government. When can we apply it? Before, during, and after policies and programs are made. We need to ask an important question. How will this policy or program affect the health of people, of individuals and families and communities? If our ultimate goal as a society is to improve health and reduce health inequities, we need to dig deeper and ask, what really are the causes of these avoidable, unfair, and unacceptable differences in health? So the root of our problems really lie in how we organize our affairs in society. These are the social, economic, political, and environmental factors around us, which we refer to as the social determinants of health. The World Health Organization defines them as the conditions in which people are born, grow, live, work, and age. And their very persistence in our society is influenced by the distribution of money, power, and resources, which eventually can lead to health inequities. Just to give you some examples of the social determinants of health, this can include but are not limited to things such as income and income distribution, education, unemployment and job security, employment and working conditions, early childhood development, food insecurity, housing, race, disability, gender, health services, Aboriginal or immigration status, hidden social safety network, and social exclusion. But why health in all policies? Why should we be interested in this? Because many of the communities that we serve actually face a variety of complex issues, and no one sector can tackle these problems just by themselves. First of all, we co-produce health. We impact health by how we organize our affairs in society. And how we organize our affairs is influenced by the policies that we have. Second, health is the responsibility of everyone, not just the health sector. Policies across sectors can have a profound impact on the health of families as well as communities. Thirdly, we need to change the policy environment. We need to nurture a policy culture in which health is the priority and measure of effective policy making. According to Dahlgren and Whitehead, there are actually layers of influence in health. Health is a product of the interaction of several factors: our genes, our biology, lifestyle, and environment. Interestingly, only 25% of our health are influenced by biology and genes, and more than 50% are actually contributed by the environment around us. Another way of looking at the social determinants of health is to consider an upstream-downstream approach. That is, the causes of the causes are the upstream factors. These are the events or structural determinants such as policy, programs, governance, and power, which can eventually lead to downstream problems such as chronic diseases, or most of which are heart disease, cancer, stroke, and diabetes. So how can we use the health in all policies approach? Two most commonly used tools for applying the health in all policies approach are health impact assessment as well as health analysis. And this will actually be explained in detail in the next presentation. I'd just like to actually provide you this infographic coming from the 2015 World Health Organization Health in All Policies Training Manual. Again, it emphasizes the need for working across sectors. NACHO also came up with 7 strategies for implementing health in all policies. But what is interesting is that it always starts with building relationships across sectors. And again, at the heart of it, being in sync in terms of our language for health as well as our health messaging. Now let me take you to Richmond County. This is actually a county situated by the Bay Area in California. It is considered as the very first in the nation in applying a health in all policies approach. Richmond County actually looked into how social factors impact the long-term physical and mental health of Richmond County residents, particularly people of color in Richmond County. In this next slide, you can see how they look at several social factors and how this affected both physical and mental health, such as the street and neighborhood and school violence, overburdened social services, high food prices, lack of healthy foods, lack of health care, economic insecurity, residential segregation, poor air quality, and lack of safe recreation, even racial profiling. This is a diagram of how Richmond County involved various sectors in their county for a whole community approach to the problem. As you can see, health equity becomes the common goal of all sectors. Richmond County Health in All Policies approach is really based on the following visions, and I'd like to highlight 3 of them. First of all, health starts long before illness. That is, we need to be healthy even before we seek help in hospitals or even clinics. And we need to allow our communities the opportunity to make the choices that allow them to live a long and healthy life. City government can and does influence health, and hence the importance of health in all policies. Now let's look at Iowa. The 2014 obesity report by the Trust for America's Health and Robert Wood Johnson Foundation shows that Iowa is the 12th highest in the nation in terms of adult obesity rate. As you can see in this slide, the adult obesity rate in Iowa is 31.3%, of which the 26 to 44, as well as the 45 to 64-year-old Iowans have the highest obesity rates. In terms of ethnicity, we have Blacks as well as Latinos having the highest adult obesity rates. How do our children fare in Iowa? Those children who are 2 to 4 years of age in Iowa are also obese, and this particular rate is 14th highest in the nation. This is a Robert Wood Johnson Foundation map showing you the trajectory of obesity rates across the country. This one in particular applies to Iowa. Based on the 2013 statistics, we have an adult obesity rate of 31.3%. And you can see that the trajectory since the 1990s up until 2013 is continually climbing. 2 years ago, the Des Moines Register actually featured a news article in looking at childhood obesity in Iowa. It featured the story of Johnny Yegi, who at 15 was already 400 pounds heavy. And according to the news article, this was a stark example of a common problem in Iowa as well as across the country. To be able to address the obesity issue in Iowa, there are 4 public policies that are needed in Iowa. First, limits on competitive foods in schools, and this actually refers to federal requirements for when and where competitive foods may be sold. Second, menu labeling laws. Iowa still do not have menu labeling laws, and these are laws which will require certain chain restaurants and similar food retail establishments to actually list calorie content information. And these are important for health education so that consumers will actually make informed choices. The next is shared use agreement. These are laws which support shared use of several facilities, like school facilities opening up to the public after hours. And last is the complete street programs. These are policies which encourage physical activity and green transportation, walking and cycling, and building or protecting urban transport systems that are fuel efficient, space saving, and promote healthy lifestyles. And all these 4 are lacking in Iowa by the time of the 2014 State of Obesity report. However, we do have good news. Just last month, Governor Branstad signed into law House File 570, which is otherwise known as the Community Use and Misleading Bill. This removes the barrier that often prevents schools from opening their facilities to the communities. Studies show when people have access to exercise facilities, they are more likely to be physically active. However, they are often hesitant to open up their facilities to the public because of liability issues. But now, this particular barrier has been lifted with the signing of this file into law. Although an improvement has been made on that area, we still need to actually look into investing in Safe Routes to School program in Iowa. This is a federally funded program for repairing sidewalks, hiring crossing guards, and removing the barriers that discourage parents from allowing their students to walk to school. Although Safe Routes to School program is federally funded, Iowa only receives limited funds, and so the state actually needs to invest in this so that it could be fully implemented statewide. So now I have 2 important questions for all of you. First, as development planners, how do you think you can use a health in all policies approach to address obesity and diabetes problems in Iowa? And second, How can we use a health and all policies approach to create and promote blue zones in Iowa? Let me give you another good news here. Last April 15, 2015, from a news article that came out from the Public News Service, Cedar Rapids and Marion were named as among the nation's most livable communities, which means that they are among the best in the nation for people being able to remain active and engaged, and to be able to get where they want to go and live comfortably and in good health. And this came from an evaluation done by AARP and based on its livability index, in which Cedar Rapids was named as the country's 7th best medium-sized city, and Marion coming in 9th for small cities. So to sum it up, how can we make health a priority? We need to target the social determinants of health, which really is the source of complicated, wicked, resistant health problems. How do we do that? Have a common language in health, where all sectors understand each other and are in sync in terms of health as well as health messaging. Working together, which include public as well as private sectors, engaging in joint policy development, which will then guide the design and delivery of city and community services. So in conclusion, for a healthier Iowa, we need to work together for health. That is, we need to have a whole of government action so that we will be able to be informed and we will be able to lead in having a state that is healthier. But what does this mean for the public health sector? This means that those of us in public health, practitioners as well as professionals alike, need to actually expand our role. We are not in opposition to other sectors, but we serve as brokers, as catalysts, as animators, as educators, and partners in a more participatory process. Thank you very much. I would now like to turn the time to our next presenter, Denise Attard-Sacco.
Hi, can you hear me well?
Are good to go.
Okay, so I'll try and make this fast. And in the next couple of minutes, we shall be taking a look at how HIA, We shall be taking a look at how health impact assessment and health lens analysis can be used to address health determinants within a proposal. And when I say proposal, I'm meaning a policy, project, and plan. We'll also go through the HHIA and HLA processes in brief and provide examples of their implement in the planning world. And finally, we'll be providing you with some tips on how to get started with HIA and HLA. So what determines health? So as you have already heard from Dr. Nobilia's presentation, being healthy does not only implicate the absence of disease. Our health is influenced and impacted by many factors, which are collectively known as the social determinants of health, and which in turn influence our behaviors and also determine the quality of life we enjoy. Listed here, as I affectionately call them, on the bottom right-hand corner is the rainbow of health determinants, and it lists a number of factors. You have individual factors such as age, gender, genetics, behaviors, which are in turn influenced by the services which we have access to, our living and working conditions, and also the social, economic and political environments that we all live in. So all these things impact our health. So what does this mean? That any decision taken on policies or projects operating outside the health sector can all influence these social determinants of health for the better or the worse. And they can lead to either positive or negative health statuses. So how do HIA and Edge HLA come into play? Using these tools, you can access how your proposal may impact the social determinants of health and what health outcomes those impacts may lead to. And then through the HIA or HLA framework, you can determine what changes you need to do to the original proposal through your recommendations to enhance the positive impacts and mitigate or eliminate the negative ones. Okay, so let's focus a bit now on health impact assessment. So what is HIA anyway? It is a systematic process which uses data and analytical methods to consider the possible impacts of a proposal on a population's health and also the distribution of those impacts. And through the process itself, you provide recommendations how you will manage those impacts. And what are its key values? So HIA gives you the chance to look at health holistically. It does enable democracy because it engages and empowers communities and therefore improving transparency in decision making. It ensures equity. Why? Because through the process you're highlighting existing and potential health disparities, and then through the recommendations you're going to come up with ideas on how to address these disparities and then ensure health equity. It also encourages sustainable development because through your recommendations, you're going to take decisions that will lead to long-lasting protective interventions and also ensures ethical use of evidence. Alrighty, so very briefly, the HIA process, 6 steps. You have screening, scoping, assessment, recommendations, reporting, and monitoring and evaluation. So let's start with screening. In the screening step, you want to decide whether the HIA will anyway add value to your decision-making process. And as well, are the decision makers open to hearing your recommendations? Because if they're not, maybe HIA is not the way to go. As well, do you have the resources to carry out the HIA? Who are your stakeholders? Scoping. You're narrowing the scope of your assessment in addition to determining how your proposal will impact the health determinants and the possible health outcomes it may lead to. Very important that the step is to set up a steering committee, which is composed of your stakeholders, and this steering committee will be responsible for determining the HIA's assessment parameters, the data sources you need to identify, and also the data collection methods you are going to use. Assessment, this is where you do the analysis proper. So through the data you've collected, you are going to build baseline conditions, and then you analyze how the proposal is going to impact that baseline. And you analyze it in a number of terms. You want to look at the direction of the impact. Is it going to be a positive or negative? What is the magnitude of the impact? Is it going to be low, high, medium? How many people are going to be affected by your proposal? Severity. Is the impact going to be something that is easily reversible, or is it something permanent and maybe can be fatal? And also is distribution. As Dr. Novilla mentioned earlier, are there population groups who are going to be impacted more than others? And if they're going to be impacted negatively, how can we address this? Then from the assessment, you're going to build your recommendations. These are based on scientific evidence, and your aim is to maximize the positive impacts of your proposal and eliminate, and if not eliminate, at least mitigate the negative ones. Reporting, of course, you want to broadcast what you found through your HIA and your recommendations. At this stage, you want to determine who your final audience is going to be, and then use broadcasting methods depending on your audience. So is it going to be stakeholders, your decision makers, and even the public? And final step, which is actually a step which is carried out throughout the HIA process, monitoring and evaluation. You want to determine the effectiveness of your HIA process on the proposal you were assessing, and also you want to track the implementation of your recommendations. Were they taken up? If they were taken up, were they actually implemented? If they were not implemented, then why? Alrighty. So, and I included this slide because I know public engagement is very important to the planning profession, and just to show you how the public can be involved in each of the HIA steps. So in screening, they can help you advocate for the HIA. Scoping, they can help you identify health priority areas for their communities. Assessment, they can help you collect the data. Recommendations and reporting, they can help you out with reaching out to the decision makers. And the monitoring and evaluation, they can monitor the long-term and evaluate the long-term impacts of this proposal on their health. Alrighty. So just a quick look at how HIA has been applied across various decision-making levels in the United States. And as you can see, like the greatest chunk has been at the local level, although we do get some HIAs conducted at state and even federal level. Okay, so areas of HIA application. I apologize, the script is really, really tiny. But the first one, which as you can see is 34%, is actually the number of HIAs that have been conducted in the U.S. have addressed the built environment. And these are just examples of how they have been used in planning. They have been used to address neighborhood revitalization plans, city master plans, public housing redevelopment, et cetera, et cetera. Okay, let's move on to health lens analysis. So 5 elements make up health lens analysis. This is engage, gather evidence, generate, navigate, and evaluate. So engage. You are reaching out. So this is where it differs a bit from the health impact assessment. The first step in the health lens analysis, you are establishing those collaborative relationships across sectors. Once you've established those collaborations, then you decide on the policy areas you are going to work on together. And that's where you start gathering the evidence. So you've decided on the policy area, how does this policy area impact health? And once you've found what those health impacts are, you're going to generate your recommendations towards this policy and also steer your recommendations through decision-making processes. And finally, you're going to evaluate how effective that health lens was making the policy ultimately more conducive to positive health. So just some examples of health lens analysis application, and these come from South Australia. It has been applied to strengthen the economic arguments surrounding active transportation, and also to assess transit-oriented development and how that impacts health. Just want to bring your attention to how it differs from how health lens analysis differs from health impact assessment. Health lens analysis, its first step focuses on building cross-sector relationships and then determining which policy area you want to work on together with the other sectors. HIA targets a particular policy plan or project. That's your proposal. And then you build those cross-sector relationships around that proposal. Okay, so how do we get started? Just a couple of tips here to get you going. So if you're thinking about doing an HIA, identify a planning policy, project, or plan that would benefit from it, and then reach out to public health departments and public health practitioners interested in becoming your partners in the assessment. With HLA, as I said, you start out with building those relationships and then determining on which policy areas you want to cooperate on. Of course, use existing data or resource sources to examine potential connections to health on the project you're concentrating on, and also identify if you have the resources available, set up timelines, and gather stakeholders. Important as well, access HIA and HLA tools available, and try to participate in HIA and HLA trainings. To do that, to help you along with that, this is a slide which has a number of resources. It will take you to, those are all hyperlinked, so when you download a copy of this presentation, you can easily access those websites. It provides you with some sites of organizations which have provided and from time to time do provide funding for health impact assessments. On the left-hand side, a number of websites which provide HIA tools, resources, and even training. The American Planning Association, together with NACHO, they have an HIA online training course. There's also a link which takes you to a number of in-person HIA training courses. And I wanted to bring your attention to the National HIA meeting. It will take place next month in Washington, D.C., and there's still time to register for this meeting. And it's interesting. It is an interesting meeting to learn more about health impact assessment and even health in all policies in general, and a good place to network with a number of experienced health impact assessment practitioners. And my final slide, I know when the planner survey was sent out, we did ask you whether you were familiar with or made use of health data sources within the course of your work. So some said they were familiar, whereas others were not so sure from where they could access such data. So on this slide, I have provided some sources of health data and split them up by different health determinants. And each item is hyperlinked to the respective website to make it easier to access the data once you download the presentation. So I've split them up by socioeconomic factors and environmental data, health data, and of course, the Iowa Gov website where you'll get general information on Iowa, and also ideas about where you can access additional data through published peer-reviewed literature. And as I mentioned, when you reach out to your communities, check out with local community coalitions and do get the public, the communities involved in conducting surveys and focus group discussions and key informant interviews. And I believe that was all I had for you today. Thank you for listening.
Okay, thank you very much to John, Dr. Novella, and Denise. We do have a couple minutes left for questions, so if any of the participants have questions, please feel free to type them into the chat tool, and we will get those answered. Also, I just inserted the presentation into the files pod, so if you would like to download PDF of today's presentation, you can do that the same way I mentioned earlier. If you just select the file named presentation and click download, it'll be downloaded right to your computer. One other note is that we will be sending you evaluation of today's webinar, so that should be opening in your browser. If you have pop-up links enabled, you will receive a message that a window is trying to open, and if you could allow that, we just ask that you please complete this survey so we can use the feedback for future presentations and just see where future needs are. So we do have one question, and it's from Janine Moody, and it's, we are interested in identifying who is planning, presently performing, or already conducting HIAs in Iowa. Is anyone else tracking this?
This is Denise. I haven't had anyone approach me yet about any HIA that is being conducted here in Iowa. I don't know, John, if anyone has approached you from the planning sector?
Not yet, no. Well, we do have some analysis going on with our projects, our new projects, but those obviously haven't started yet, so haven't become a part of that at this point.
I'm not sure.
Maybe there's some of our attendees that are aware of some of those things as well.
Sure, if the Iowa Department of Public Health is keeping a track of this, so that it would be an entity that would be good to ask this question to as well.
We can certainly follow up on that, and if we do hear about any HIAs going on, we can certainly let Janine and the Public Health Association. All right, any other questions from participants? Well, again, I just want to thank our presenters, and then I also want to thank all of you for attending. We greatly appreciate it. And if you do have any tips or resources that you want to share, please be sure to include that in your evaluation or feel free to contact us. I will be sending out a link of the presentation to all of the participants so you guys can share it within your networks. So if there are no other questions, thank you for joining us, and enjoy the rest of your week and have a great Memorial Day weekend. Thank you, everyone.
Thank you.
Allie, are you going to hang around for a minute?